Okay, folks, good evening. This is the voice of your invisible moderator, Ramon with TPN Health. I'm going to be serving as technical moderator for tonight's presentation, and I want to thank everybody for joining us and being part of the many voices who are here to listen and also to be heard. So I want to go ahead and thank all of our presenters for being here tonight. What we're going to do is we're going to have everybody, just so you know, by default, everyone's microphone is muted and the videos are turned off just to kind of keep things a little manageable. But we have a number of people on our panel. I just wanted to go ahead and just kind of provide a soft introduction while folks are starting to trickle into the attendee room. But I want to point out a couple features, namely there is a questions panel that everybody's going to have access to. If you take a look at the control panel that should be appearing on your screen, this is an opportunity for you to type in a question that you might have, especially if you have any technical issues that you might be encountering. I'll do my best to communicate with you non-verbally and write back. So if anybody's experiencing any trouble during the presentation, I'll go ahead and try to address it and see if we can solve the issues to the best of my ability. I'm going to go ahead and hand it. Oh, I also wanted to point out, you may notice other features, but we're not intending to run any polls tonight, nor do we have any handouts for this presentation. This is primarily going to be a verbal conversation. So with that, again, as a reminder, if anybody has any issues that they need to communicate, please look at your questions and type in a question there, and I will be observing as they come in. So I'm going to go ahead and hand this over to our CEO, Trevor Colquhoun. Trevor.
Thanks, Ramon. Just wanted to say a quick thank you to everybody for joining us. Wanted to say thank you to our main panelists, Dr. Bisco, Dr. Dean Leveist, and also for moderating Patrick Bordnick, Dean of School Social Work here at Tulane. Also want to take a moment to talk about real quickly why we're doing this as a company, fit our value system. It also fit our value system to give back during this moment. We brought Sonny Lee on, who's the head and founder of Son of a Saint. And we want to give him a moment to talk about the good work that he's doing and has been doing for over a decade here in the community in New Orleans. And as you know, everybody who attends, $5 will be donated to Son of a Saint. But don't let that stop you at all. Please yourselves reach out if this is something that touches you and donate to Son of a Saint. They do fantastic work in the community. And you know, as we believe, and always, it's been something that I've personally supported for a long time. We'll have long-term gains to our community. So Sonny, if you have a couple of minutes to just kind of explain really what Son of a Saint is about.
Yeah, sure. You know, thank you everybody for being on, especially those who are supporting us. You know, we started back in 2011. We started the program. I'm from New Orleans. My father played with the New Orleans Saints. He passed away when I was 3 years old. So I was lacking some male guidance really until I got to St. Augustine High School and had some great work experiences. And so I wanted to make sure that boys in the New Orleans area really were guided by mentors, had great education, mental health support, travel, and a plethora of experiences. So we have about 100 boys in the program, and we're growing, probably close to 150, 200 by the end of 2021. And so boys join at about the age of 10, and they're with us until they're really 21. I mean, it really doesn't end. So the relationships last forever. And so we've got a few classes that have graduated. Actually, we just have a boy that's going to West Point now. Actually, all of our seniors are going to college, first generation college, under scholarship, which is we're very pleased about. So we're here for a long haul. We're here to make sure that our boys become the next leaders of our communities and be on boards of education. You know, leading healthcare systems and really changing the way it looks right now, and making it more equitable, even a lot of what we're talking about today. So thank you all, and thank you, Trevor, for your leadership.
Thank you, Sonny. Appreciate you coming on, and grateful for all that you do. Now, without further ado, I want to get into the topic this evening. Again, from the TPN side, we're very grateful for Thomas and Belinda to be here. They've spent their entire careers studying, being published on this topic. And Patrick is a friend and colleague of Thomas's and has known Belinda in the past. So we were very fortunate enough to have Patrick lead this conversation. I'm going to cut off away from this now and listen and learn. Thank you.
Thanks, Trevor.
Good evening. I'm going to kind of kick this off a little bit here. And the title of the event is Inequitable Access to Behavioral Health Care for Black Americans. And again, being the Dean of Social Work, health equity, health disparities, and addressing these things is long-term rooted in our values as social workers, as well as public health practitioners and everybody, and it becomes a topic. If you see someone popping in and out of my camera, I believe that all generations should hear this discussion and learn historical factors, as well as where we're at today and where we need to go in the future. So my oldest daughter is here with me tonight, and I think this is important that we all share these conversations with our families and our friends. And so I'd like to first introduce, I could do pages, but Dr. Leviste and Dr. Bisco, we had a call last night, and it ended up going an hour plus because we were all so passionate talking with one another. And they had said, just say a little bit about me. So I grabbed a few things. So Dr. Belinda Bisco is the interim senior vice president for University Outreach and the College of Continuing Education at the University of Oklahoma. Long history of research, being a research psychologist, as well as a certified drug and alcohol program director and administrator, internationally certified in prevention. I know Belinda from doing work here in New Orleans. She has a great conference talking about access to drug and alcohol treatment and mental health care. She's secured well over $200 million in funding to support these types of programs, and has a long history, and I'm so thrilled that she's here to talk about that, because we don't talk enough about mental health as well as drug and alcohol misuse. Dr. Thomas Leviste is the Dean of the School of Public Health and Tropical Medicine at Tulane University, is a friend, a colleague, is an expert in minority health issues, cultural competencies, and looking at access to care, looking at current factors as well as historical factors, and shares a wealth of knowledge. He's a documentary filmmaker and has a wonderful website, The Skin You're In, and I'm sure he'll talk a little bit about that. He's a member of the National Academy of Medicine, as well as National Academy of Sciences members. So please join me in welcoming Dr. Bisco and Dr. Leviste to the panel. And we chatted a little bit about, and I asked them to provide me some lead questions. And as we get questions from the audience, we'll sort of pull those into the discussion. But I think it's very important, as well as our presenters and our panelists tonight, is answering some basic things and questions of what we hear. We hear terms all the time, and we say terms, but we don't know the meaning behind them or have an idea. So part of this is to provide that base level of education so everyone can have discussions going forward. So the first question, and I'll turn this over to either Thomas or Belinda. Could you guys share with us what is meant by systemic racism?
I'll defer to Belinda first.
Well, that is such an important question, Patrick. And, with everything that's going on in our country, we're hearing a lot about the systems in our country. So when I think about systemic racism, I really think about all the factors that go on in our country that work to produce and maintain racial inequities. And so a lot of these things, as we know, are rooted in our history and our culture. And these things basically allow the privileges that are associated with whiteness and the disadvantages that are associated with color to remain deeply embedded with the political economy. So when I think about things such as public policy, when I think about institutional practices, and just what we would refer to as cultural representations, all of these things contribute to what I call systemic or structural racism. I mean, you can look at the color of my skin, look at the color of Thomas's skins. We represent some things differently in terms of just physical appearances that typically would not be perceived as the American standards of beauty because we're not blonde-haired and blue-eyed. So it's the maintaining of all of those things in our society, in our institutions, that give more advantages to whiteness than to people who are different or people of color. Thomas, I'll pitch it to you. You'll probably want to add something to that.
I mean, I think that was an excellent answer, and I'm gonna just kind of embellish it a little bit by broadening beyond just systemic racism and say that there are really 3 levels of racism. And I think that's really key to understand, because when you hear the term racism, typically what people think in the media, or when I have conversations with people who don't really think about these issues a lot, they focus on bigotry. They focus on an attitude, a belief system, people who believe other people are inferior. And I think most people do not hold those attitudes, right? So they say, well, I'm not bigoted. I don't think other people are inferior to me, therefore I'm not racist. But there are 3 levels of racism, 3 types of racism. There's internalized racism, there's interpersonal racism, and there's institutionalized or structural racism. So first, internalized racism. The value, the belief system that says that Black Americans are inferior to white Americans is the core of what this interpersonal racism, that attitude, that bigotry, that belief in this white superiority. Well, that value is an American value, and African Americans are Americans also. And so African Americans themselves can exhibit attitudes of racism towards other African Americans. This is the internalization of a belief system that really permeates much of the country's history going back 401 years, right? So that's one, is internalized racism, which is about the people who are subject to the detriments that come from racism themselves believing the negative attitudes about African Americans. And this is how you have crime. It's easier to kill someone over a pair of Air Jordans if you believe that that person's life is not valuable. And so that's one level. The second level is interpersonal. That is bigotry. That's what most people think of when they hear about racism. Somebody has an attitude towards somebody else and therefore does something harmful to this other person because they simply see that other person as being inferior. And quite frankly, I think that is the least important of the 3. Structural or institutional racism is the third category. And structural racism doesn't require anyone to believe anything. It doesn't require that anyone do anything. We simply let the way the society is organized play out, and it will have a racially differential outcome. So an example of that is the fact that in this country, we do not teach the history of this country as it relates to race. We simply don't teach it. And I know many people listening in think that they do know the history. I think most Americans, most people that have been educated in this country do not know the history because we don't teach it. For example, I have a quite good education, I think, by any standard. I didn't know that there were African Americans who fought in the Civil War until I was in graduate school working on a PhD. So the fact that I could go from kindergarten graduate from high school, go to a great college, have a 4-year degree from that college, and then go on to graduate school where I'm working on a PhD and not know that not only were there African Americans in the Civil War, that there were African Americans on both sides in the Civil War, and that there were 32 African American soldiers that won the Medal of Honor. So something that is that important, and the fact that most Americans, I would venture a guess that most people that are listening in on this call also didn't know that African Americans fought in the Civil War, right? So that is institutionalized racism. So if you're able to write the history books in such a way that you don't talk about important aspects of history, especially important aspects of history that reflect positively on the group that is being targeted, in this case, African Americans, then the institutional racism just continues and it operates naturally without anyone needing to do anything. Because now you go to school, you read the history book, it wasn't in the history book, so you didn't know that was the case. So now you go through life believing that African Americans did not fight for their freedom from slavery. That is how institutional racism operates. The result there is, so we have a program called Social Security in this country, where you can get sort of retirement benefits from the federal government that you pay into throughout your adult life, and when you're 67 years old, you're able to get to get access to that benefit. But if African Americans' life expectancy is lower, is 69, 70 years old, then the African Americans who are paying into that system will not get the same benefit out of the system, even though they paid into it. This is not intentional. It's not that someone is establishing a policy. The head of the Social Security system is not sitting there and saying, okay, African Americans are not going to get benefits and whites are. It's embedded into the structure of how the system operates, and as a result, there's a racially differential outcome. That is the way structural racism operates. If you have a school system that says we will fund the public schools on the basis of taxes, property taxes of the neighborhood where the school is located, then if you live in a low-income neighborhood where the property values are low and there isn't much tax revenue, that's going to impact the quality, the amount of resources that this school has, as opposed to living in a more affluent community with more expensive houses, which will generate more tax revenue. And as a result, those schools will have more resources. No one need do anything in order to have these racially differential outcomes. They operate as a natural course of the way the society functions. That is structural racism or institutionalized racism.
So Thomas, you said so many important things. One of the things I'd like to do this evening is take some of our academic learning and research and ground it in some just real life experience. I want to go back to what you said about internalized racism, internalized oppression. Really, that struck a chord with me, and I want to share a little story. And it's probably not unfamiliar to you as an African American man. I grew up in the Deep South under segregation and Jim Crow. Here's a real life example of that internalized oppression. As a little kid growing up, I won't say the city unless somebody asks me, but it was in the Deep South.
What city?
Atlanta.
Okay.
Very segregated and very, very much representative of everything you talked about. But as a little black girl growing up in Atlanta, I didn't know it was internalized oppression at the time, but we had a little nursery rhyme in my neighborhood. We'd get our jump ropes, we'd jump, and the quote went like this: if you're white, you're all right. If you're yellow, you're mellow. If you're brown, stick around. If you're black, get back. And we would jump and we would say that little nursery rhyme, never realizing as kids how much we were being taught to basically hate who we were.
Yep.
These are the kinds of subtleties that go on in our society that then cause those of us who are victims of structural or systemic racism to really begin to oppress ourselves as well. And so I just want to affirm so much of what you said and just kind of bring it down to real people and real lives and how that sometimes manifests itself. Those things manifest themselves in our communities.
Well, I remember that rhyme. I remember that game, that rhyme also. And I did not grow up in a city in the South. I grew up in a city in the North, and I won't say the name unless someone asks me.
Okay, tell us.
Where at, Tom?
Brooklyn, New York, in Brooklyn, New York. And I remember see girls out playing and using that same rhyme in the North, in New York. And this would be in the 1960s and 70s. And I'm gonna and further personalize this. I'm gonna ask everyone listening in to do a little experiment for me. I want you to close your eyes for a second, and I want you to visualize Jesus. What does Jesus look like to you? Now, I'll bet you, most of you, what you saw when I asked you to do that was a white male, upper 20s to maybe early 30s, with a beard, blue eyes, and blonde hair, okay? But what we know about the historical figure Jesus is that given the region that he came from, it is extremely unlikely that he looks anything like that. And everyone here listening intellectually knows that. But the fact that that image of this blonde-haired, blue-eyed Jesus that we all hold in our minds, that everyone, blacks, whites, every American, I would bet, most Americans, I bet, had that same vision in their mind. That is how racism seeps into every aspect of culture and impacts everything that we do, and why it's possible for people of the race group that is being targeted by racism to actually hold negative values. Because if you believe that the representation of God, right, is a representation that does not look like you, and especially when it's more likely that the actual Jesus looked more like me than that picture, that's what we're talking about. This is how deep.
Well, hearing you talk about that song, Belinda,
Yes.
I will share it. It's not when you were a little girl. My daughters who were in high school here in New Orleans, I wasn't going to say, do you know where I'm at now? Because you both do, but they came home and said, there's kids that are singing, these young kids are singing some kind of birthday song, and it has something about Chinese in it. My daughters are Chinese, and it has something in there. And they said, that really bothers us. So again, we go back to this. You were a young woman in Atlanta. This is how many years later, and my daughter, whose oldest is 17, and these songs still get there, and people sing them, and they're not even thinking that there's anything making a connection about it. It shows that we think we've come certain ways, but I think Tom's right. With this systemic things that happen, people don't ever question them. It's just sort of, well, that's what we always sang. That's what we've got to question now.
Right. And, you know, I would sort of throw out to this, and again, grounding things in reality. My oldest daughter is 40 years old. She's a psychologist now, very accomplished. When she was in preschool, this is how much the system doesn't change. She was a little 3-year-old in preschool at a very prestigious private preschool in Oklahoma. And one day she comes home from preschool crying. And I'm just very concerned as her mommy who loves her. And I asked her what the problem is. And she said, Mommy, we play a little game at my school called Orphan Annie. And everybody takes turn being little Orphan Annie. But today, when it was my turn, they said to me, Brandy, you cannot be little Orphan Annie because little Orphan Annie is Black. Now, that was before the Broadway play, before there was a Black Orphan Annie. Because you are Black, these are 3- and 4-year-olds. You cannot be little Orphan Annie. You must be the dog. So she comes home just heartbroken. Now, I believed in equipping my kids with the tools, the knowledge and skills, even at a young developmental age, to handle something if I thought they could handle it. As her mommy, I said to her, Brandy, what I want you to do is to go back to preschool tomorrow and tell your friends that little orphan Annie represents all the orphans in the world. And they come in all shapes, sizes, religions, colors. Now, I know she didn't have a clue about what I was saying. It didn't matter. The next day, she goes to school. She shares this with her little preschool friends, whose eyes were probably rolling in the back of their heads, too. She comes home smiling. And I said, what happened? She said, Mommy, they let me be little orphan Annie today. I'm sure all those little preschoolers were saying, well, if Brandy's mom said this, then we've got to let her be little orphan Annie. And the point I'm trying to make here, we step back, we look at these issues, and we wonder why they continue to destroy us personally, professionally, destroy our institutions. And I think so much of this is steeped in the fact that there is such a lack of awareness that we pass along these implicit biases from generation to generation. If anything comes out of what's happening now, I hope that we're able, I'm always saying to college students, the protest is the beginning. It is not the end. What happens? Help me understand. What happens after the protest? I was in college when Dr. King was assassinated, met him in the Atlanta airport, had the wonderful opportunity for one brief moment in time to shake his hand 6 months before he was assassinated. 6 months later, my historically Black college, university, Fisk University in Nashville, was up in flames. The National Guard on our campus, a building burned down, street lights being shot out by the National Guards. There were protests. I'm not going to say how old I am, not important, but decades later, we're seeing the same thing happen again and again and again. When are we going to deal with the policies, the practices, the deep-rooted things, the implicit biases that put these invisible barriers around us that basically say one group is superior and better than another? We must begin to get to the root cause of these issues.
So I think within that 100%, we have to change. Within that, we often hear people say that race is a social construct. What does that mean, or what are people trying to say or trying to go with a statement like that? Tom or Linda?
Yeah, so how do we determine what a person's race is, right? If you're walking down the street and you see a person coming towards you, and all you have is your visual assessment, how do you determine what that person's race is? You determine it on the basis of a limited set of visual differences, phenotypical differences, such as skin color, the most common one, skin color, hair texture. Maybe there are some secondary characteristics like the shape of the person's nose or something like that, right? And that's what that is. Think for a moment about the degree to which any of those things have any implications for a person's health, right? There's no science that says that your skin color should determine your blood pressure, that the shape of your nose should be associated with your likelihood of getting cancer. I mean, there's nothing scientific or biological about that, right? Because this concept of race is a social construction. Humans vary across a wide variety of characteristics. If a person was standing at the equator and they walked north from Africa into Europe, and let's assume that Mediterranean Sea wasn't there, and they were able to just keep on walking all the way up to the northern part of Europe. At some point, you would find that when you're in the beginning of that journey, the people you see are all really dark, right? Dark brown skin color. By the time you get to the end of that journey, you'll find that those people are very light, right? Very fair, white skin color, right? Or pinkish white color, right? But there's no point along that journey where you will cross a line and say, okay, I've now crossed from where the black people are to where the white people are, right? Because there's a gradient, there's variation. And what we do with race is we try to take that human variation that is a spectrum across a wide variety of characteristics, and we try to create categories and place people into categories. Right? And we do that on the basis of social, cultural, and political decisions. We decide that this person is in this race group because they have these physical characteristics, and this person is in that group. These are decisions that are made, and they're the decisions that have been changed over time. So if you look at, this is a slide that I show in my classes. I show a slide that lists the way that race is measured on every U.S. census. The first U.S. census was 1790. The most recent one was 2010. And this shows the way that race was measured in every single census from 1790 to 2010. And you'll see how many times we've changed the categories, how they've changed, how people are defined. Until the early 20th century, we had a category called mulatto. We had a category called octoroon and quadroon. Mulattoes were people that were half white, half black. Octoroons were people that were 1/8 black. Quadroon, people that were 1/4 black. What happened in the 1920s is that there was a rich person in Virginia who died, had only one heir, right? The only heir was this mulatto son that he had. So he was to inherit that fortune, right? And the courts decided that mulattoes were black, and black people could not inherit property at the time in the 1920s. So they made a ruling that since this person is half black and half white, this person will be considered black and therefore not able to inherit that fortune, and therefore the fortune would go to the state. When that happened, the U.S. Census Bureau changed the way that it measured race again, and no longer categorized mulattoes and octoroons and quadroons. Therefore, the one-drop rule was created. If you have one drop of non-white blood, you are whatever that one drop is. What is the scientific basis for that? So we have a concept called race that is determined by cultural, political, economic decisions made by people who have the power to make those decisions. And as a result, you look at Colin Powell, who has 2 grandparents from the UK, has 2 grandparents from Jamaica, and he's born in the United States. And we consider him African American. You have Barack Obama, who has 2 grandparents from Kenya, which is East Africa, by the way, which is not where most African Americans' African ancestry comes from. And he's got 2 white American grandparents, but we also call him African American. We have Tiger Woods, the golfer. He's got 1 Chinese grandparent, 1 Thai grandparent who also has Chinese ancestry. He's got a white American grandparent that also has Native American ancestry, and he's got a black parent who has Native American and white ancestry also. So what is he? He says that he's Caucasian, which is literally true, right? Because he's got ancestry from various ethnic groups from around the world. But we consider him African American too, right? So clearly, race is not a biological concept. It is not being determined by biological factors. It's being determined by cultural factors, being determined by decisions that we made. As a society, we have decided that one drop of African blood makes you African, therefore African American. And just as we made that decision, we can make a different decision. So if you have a couple, one is African American and one is white, and they move to Brazil and they have a child in Brazil, and then they move from Brazil to the United States and they have another child, those two children could be considered different races, even though they have the same two biological parents, because they were born in different cultures that handle these race mixing differently, right? So in the United States, we would say that child is an African American. In Brazil, they would say that that child is a mulatto. Race is a social construction because it's decided by cultural factors and not by biological factors. And this is a real complication for the public health research that we do and medical research, because it's very common that people in medicine are confused into believing that race is a biological construct and not a social construct, because you can visually see the difference between somebody with dark skin and somebody that does not have it.
Big fat ditto on that. I couldn't agree with you more. And the added complication, Patrick and Thomas, in my opinion, is that because race is a social construct, we use it to make assumptions and identify people based on what they look like. I would contend that someone like myself, who grew up in the deep South under segregation and Jim Crow, whose parents grew up under segregation and Jim Crow, whose great grandparents grew up under slavery and segregation later and Jim Crow, is going to have a very different upbringing than someone who looks like me, who had a white parent who was their primary caretaker, white grandparents, but who happened to have a parent from the continent. They may have in our social construction the identity of African American, but it doesn't really define their experiences except how the world might perceive them, treat them, but that socialization from that immediate family or those guardians who may have raised that child will be very different than someone like myself whose ancestry was steeped in centuries of slavery and racism. In this country, we look at people, we look at those physical characteristics and make assumptions about everyone who looks that way. It's very interesting. I think it's something that we're going to struggle with more and more. And going back to what you talked about earlier, Thomas, internalized oppression, I think sometimes that African Americans, and we all, I think many struggle with this in terms of this double consciousness, as some race theorists talk about it, are living and keeping a foot in two different worlds, trying to reconcile these differences sometimes. And as you grapple with that double consciousness, I can't tell you now that there's a category, I believe, on the census for people to identify as biracial. I will tell you that despite the fact that my roots are in the South, I obviously have done my DNA through Ancestry, as most Blacks whose lives were connected in the South have white ancestry. I will always identify myself for who I am, which is an African American woman. I think it's important for political reasons. I actually worry about people feeling so much internalized oppression that they choose not to identify with that one drop rule, because I think giving recognition to what some of us have experienced through this badge of color becomes important. Numbers matter. People look at those numbers and numbers count. And so for me, and I'm speaking personally, I will always acknowledge the one drop rule. I want people to know that I am Black because it tells you a lot about my history as the descendant of a slave and my family's history and what that means in terms of life in these United States.
So this is very powerful stuff in thinking about the systemic racism, obviously looking at constructs and how healthcare is viewing patients coming in and making assumptions about all sort of things. How do we see this play out, racism affecting people's health, not only in general, but also when they are introduced into a healthcare provider or a system? How do both, I know both of you have spoke widely on this topic, so I think it's very important for people to hear not only the systematic issues, but also these perceptions people come in on social constructs or belief systems that are clearly faulty, that have existed forever.
Thomas, you want to start?
Yeah, they're faulty belief systems, but they're belief systems that are dominant in the culture, and everyone believes them because that's what they've been taught to do. And I say everyone, I mean literally, including African Americans, and thus you have internalized racism. You believe it because that's what you've been trained, that's what you've been taught. You know, so there was a study that was done a few years ago at University of Virginia Medical School, where they asked the medical students a question about race differences and pain tolerance. And what that study showed was that the medical students believed that African Americans had greater pain tolerance than whites, which may explain another study that was conducted, actually conducted at UCLA and then conducted again at Grady Hospital in Atlanta, Belinda's hometown, where they looked at patients that came to the hospital emergency department with a long bone fracture, meaning basically a broken leg, right? And what they found was that among patients that came to the hospital with a broken leg, that the Black and the Latino patients were less likely to be treated for pain. Now, this is not some ambiguous diagnosis, right? You look at an x-ray and you see the bone is broken. It really doesn't take a tremendous amount of medical training to look at an x-ray and see the bone is broken. This person must be in pain. But yet the African Americans and in the UCLA study, the Latinos, less likely to get pain medication. It is because there's a belief system that African Americans are more tolerant of pain. Therefore, if they're complaining of pain, they may be exaggerating, they're being dramatic, it may not be as necessary in their case. This is how these belief systems creep into the actual practice of medicine.
Yeah, and what I would add, you know, you ask an interesting question. Generally, when we think about health equity, we think about all the things that give people more access to good health. Usually, if we have access to money, wealth, power, prestige, as you'll see in the literature, then people who have access to those things are generally going to have access to the best health care that we have to avail ourselves to. The World Health Organization defines health basically as a state of complete physical, mental, and social well-being, not just the absence of disease, which is what I think we often think about. If we're not sick, we're okay. Some of my colleagues, the Wolans, in a book they wrote on resiliency once, defined kind of well-being, mental health this way: living well, loving well, playing well, working well, expecting well. That begins to put together for me the kinds of things: living well, loving well. The combination of all of those things speaks to a state of wellness and health. The lack of those things determine less access to the ability to avail ourselves of good health care. And unfortunately, if you look at the data, the health of African Americans is the worst of any group in this country. The worst. Higher rates of obesity, diabetes, higher rates of childhood obesity. So much of this is steeped in cultural issues, racism, lack of opportunity and access to those social determinants that I talked about earlier. And so health equity for me is a huge issue. Let me give kind of a laywoman's example here. I've got Patrick, Thomas, and Belinda talking this evening. We all need a pair of shoes. I give me a size 11, Patrick a size 11, Thomas a size 11 shoe. The shoe is too small for Thomas, fits Patrick perfectly, is too small for Belinda. That's equality, giving everybody the same thing. Equity is about giving people what they need. I need a size 7. Thomas needs a 13. Patrick was the only one who needed the size 11 shoe. That's basically what we see happening oftentimes in our healthcare system. Even if people get what somebody else got, it may not be exactly what they needed to deal with their unique needs or disease which is further progressed. We know that often when we as African Americans go and seek medical care, the disease processes are often further progressed. And so the prognosis, the outcomes are not going to be good for us because of the lateness in the disease process that we seek care. So I think this issue of health equity, and I do want to emphasize the equity word, is really something, and COVID-19 continues to show us the inequities of healthcare, especially among people of color and African American people in particular.
I think that's a great thing. You brought up a lot of great terms that we're hearing a lot now. I think it's a good time for us to get a much clearer definition so people that are on the event can walk away with this, understanding these terms, because they're being tossed around in newspapers, the media. What are health disparities, and then how do health disparities differ from health equity, and how do they interplay upon one another?
Thomas, you want to start on that?
I'll take that. And so there's a third term, which is so you have health differences, you have health disparities, and then you have health equity, right? So differences would be you have two different populations and they have different health outcomes. An example would be men and women and breast cancer. So we know that women are much more likely to get breast cancer, much more likely to die from breast cancer than men are. Men do also get breast cancer, by the way, in case there's anyone who didn't know that. Now, is that a disparity? No, it's not a disparity. It's a difference. The physiology of males versus females is such that women are at greater risk of breast cancer. Therefore, women have higher rates of breast cancer than men. That is a difference. That is not a disparity. A disparity is a difference that results from something that is disparate, something that is not right, something that should not be. So a difference in breast cancer between Black women and white women is a disparity. There's no physiology that says that Black women should have a higher rate of breast cancer or a higher mortality rate. Actually, there isn't a higher rate of breast cancer, but there's a higher rate of mortality from breast cancer between white women and Black women. That is a disparity because that is indicative of something that's not right. Now, what that thing is, we can then parse that out with research. Is it access to care? Is it something about the health behavior of Black women? Is it something about the exposures that they're getting to health risks that's producing this difference? But there's something that's producing this difference, and it's not something that is natural. Health equity is the aspiration. We aspire that we would not have any disparities, right? That all people would have similar life expectancy, similar quality of life, and similar length of life, and that we wouldn't have these disparities. And in order for us to get health equity, as Belinda pointed out, we need to, if we're going to equalize and have equal health outcomes, we're going to have to engage in equitable or in strategies that are about equity. That is, giving different populations different resources that's necessary for their health to improve enough so that all groups have equal health outcomes.
And Thomas, I want to build up, so well stated on that. You know, we talk about our systems, our institutions. I belong to a women's organization. I think I heard Thomas mention it in a conversation we had, the Links Incorporated, which is a national women's civic organization engaged in some tremendous work around this country. One of the initiatives that the Links Incorporated have that's been going on for a while is with the Mayo Clinic. And one of the things that we know about us as African Americans is we're often missing from a lot of clinical trials that go on in this country to address diseases that sometimes manifest themselves differently in those of us who are of African American descent. And so one of the initiatives that we've been involved in at that level is really trying to get more African American women, for example, into clinical trials around breast cancer, because we know that there are some manifestations of breast cancer with African American women that present differentially. If we are not a part of the research and the studies that are going on, the medications that are developed, and all kinds of other things that might eradicate or treat more effectively some of these diseases amongst us as African Americans, when the manifestations and the disease progression could be is seen in different ways, the changes just won't happen. This for me also speaks of health equity. Are we actively engaging, recruiting, getting African American men and women and children involved in these research studies that will allow us to look at differences and different outcomes, different solutions, so that we begin to move towards more equity and thus arrive at equality, as Thomas mentioned.
Oh, I have a question. What are the primary health disparities that we're seeing or experiencing in African Americans?
Wow. I'll jump in there and then I'll toss the ball to Thomas. There are high rates of obesity. We have significant levels of childhood obesity, and you know, you can find these data in research articles published in a number of places. High blood pressure is one, and I think that's one that researchers continue to grapple with. Thomas, you can correct me if you have different data. I don't know that anyone really understands why there is disproportionately such a high rate of hypertension among African Americans in this country, because if you look at the continent of Africa, from what I've read, the data seem to indicate that there's more of a normal distribution of hypertension. I've heard some theories. The theories that I hear about have been debated, and whether they're steeped in any reality, I don't know. One of the theories that I've often heard that was intriguing, and I'd like for the two of you to weigh in if you've heard anything about it. There's some theorists that have postulated that when slaves were brought over from the continent, that those who survived may have had some sort of genetic mutation that allowed them to retain fluids, i.e., as a result, salt that then contributed to their surviving the journey, because the journey was so brutal and vicious. But that survival, some have then theorized, and I don't know that it's steeped in any data or reality, you can read about it, but some have theorized that those slaves who did survive the journey, that now those of us who are descendants, the good news is because they survived, we are here. The bad news is it is by some researchers theorized that it may have something to do with a predisposition that those who survived were able to retain enough fluid to make the journey to this country. I don't know if that's true or not. There are all kinds of things out there. Thomas is jumping at the bit to jump in, and so I want him to jump in. But I'll just say quickly: heart disease, hypertension, prostate cancer among African American men. And of course, prostate cancer, as we know, is one of the slowest growing, most treatable cancers out there. My first husband was a physician, and he used to say to me when he was in medical school at Meharry Medical College, Belinda, most men will die with prostate cancer, not from it, but with it, and not even know they have it. We unfortunately have high numbers of African American men dying from prostate cancer because of late treatment. The last thing I want to say as a psychologist is we also see challenges with mental health issues in the African American community. I did a study over a decade ago looking at disparities with mental health care in Oklahoma City, and had funding to work with a team of many people to look at this issue. And we went around the city conducting interviews with people who were homeless, people with disabilities, folks in the LGBTQ community, because with all of our marginalized groups, we see challenges. But one of the findings that emerged in the study that we did was that among African Americans that we interviewed and studied was this stigma that was attached to mental health, and that the family's responsibility was to take care of those with mental health issues, and that this was not something that the society, a psychiatrist, and so these issues went underground and then resulted in a lack of appropriate care and treatment. So these are some of those disparities that we talk about, that we continue to see around health issues in the African American community. I'm going to be quiet and toss the ball to my colleague, Thomas, because I can see he's anxious to jump in here.
Yeah, I'm anxious to jump in.
Thomas, can you also, you shared with us last night about allostasis and stress. As you lead into addressing the initial piece, can you also talk about that and how that structural racism impacts health? That was such a wonderful talk we had last night, and I think it's important for people to hear.
Yeah, I'm happy to do that, but I have to respond to the salt retention theory during slavery and say that theory has been, I don't think I'm exaggerating to say that it has been totally discredited.
Oh, good. That's good to know.
And, genetic mutations don't happen that quickly. I mean, the Middle Passage typically was about 4 months, and you're not going to get a genetic mutation in 4 months in one generation. Also, there was an article, and I'd be happy to share these articles with you. There was an article published in the American Journal of Public Health by a historian, which showed, which you know, through historical methods, was able to demonstrate that that the slave traders were very much aware of the need to have salt on the slave ships, and that there was no shortage of salt on the slave ships. So that isn't accurate. And then there was another beautifully written article, Jay Kaufman, who's at McGill University in Canada, wrote where he basically searched down at the origin of that hypothesis, demonstrated that there was never a study. It was a hypothesis that someone put out at a conference and people picked up and started talking about it. And there was never any study that proved that was the case. So there's really just no evidence of that. Now,
Right. And let me just say, I knew that there was no evidence. I just thought it would be interesting to throw it out there because people have tossed it around so much. But you're right, it was only a hypothesis, a theory, and no evidence.
yeah, I try to be careful. I mean, it's a myth that I would love to see that myth die. And so I try not to talk about it too often because I don't want to give breathing
Yeah.
into it. But thank you, Belinda, for breathing life into it.
I didn't mean to. I just thought
I'm just
one of the myths that's been out there, even though there's no proof to it.
yeah. I'm happy to share those papers with you. They actually, I think you'll find them both very convincing that there isn't any support for that theory. And Patrick, I forgot what you wanted me to talk about.
The part about cortisol.
Fight or flight.
Cortisol and stress.
Right. So we're trying not to use too many technical terms, right? So fight or flight, right? So what happens if a person is under stress or duress, or they think that they're in danger? The physiologic response is the response that we call fight or flight, right? Your body gets ready to either fight to save yourself from the danger, the predator that's coming to attack you, or whatever it is, or to run away, to get away from the danger, right? And how does your body do that? It generates two powerful stress hormones, cortisol and adrenaline, which make you able to react more quickly. Your reflexes are faster. You breathe more heavily so that your heart is pumping more blood, so that you get more blood into your muscles and you become stronger, so that you're better able to either run or fight, and you're reacting more quickly and you're reacting without thinking, right? That's basically what happens. And I'm sure everyone can think of experiences they've had where they've the body has sprung into action and they've done something and without even thinking about it, but it turned out to be the right thing to save themselves or save someone else. So if you are a person who is living in a community with a lot of violence, a community that's dangerous, where you know that you are potentially at risk, or you're a person that is under stress because you have financial problems, you can't pay the bills, you can't figure it out, or you're working someplace, you're one paycheck away from poverty and homelessness, or you're being mistreated at work, your body goes into that fight or flight response. If you're living chronically in that type of condition, then your body is always in that fight or flight state, which means that your blood pressure is always high. It's not necessarily high because of any other reason other than your body is in that fight or flight response state, because you're constantly worried about your safety. Your body is always producing high levels of cortisol, high levels of adrenaline, and that begins to degrade your organs. And as a result of that, we start to develop these chronic conditions that we know are the leading causes of death: heart disease, cancer, stroke. The three leading causes of death in the United States. Heart disease and stroke both are the ultimate result of uncontrolled hypertension, right? And we know that hypertension is the condition that is most responsive to social, psychological phenomena. So if you're constantly under stress, you're constantly in that state, the first thing that we're going to get is you're going to become hypertensive. And over time, the hypertension will evolve to stroke. So I believe that's primarily what's happening to many African Americans, and why African Americans have higher rates of death from the leading causes of death. We also acquire those conditions at a younger age on average compared to whites, and as a result have a shorter life expectancy. And so it's sort of this premature aging that occurs, and it occurs because of these social, stressors, these economic stressors, these psychological stressors that you're living under.
Well, thank you, Tom. That was great. Just like you said it last night, it really dispels a lot of myths and hits it home for us all. And so what would you say, obviously, some of the issues, what are root causes of a lot of these health disparities that we're seeing in African Americans that people need to understand? And if you had to give a couple take-home messages tonight that would stick with people to figure out how to go forward, what would that be?
You want to go first, Belinda, or you want me to take it? I'll go.
You go and then I'll jump in.
I would say if I was going to pick one, and there are several, but if I was going to pick one, it would be the fact that we all live in the country together, but we experience the country very differently because we are racially segregated. We no longer have Jim Crow laws, but we still have an extremely racially segregated country. And as a result, we're experiencing the country very different. We have differential access to everything. If you live in a predominantly African-American community in most cities in this country, you live in a community that does not have the businesses that your 14-year-old child can get that first job so they can get that first foot on the ladder to employment, to start to learn how to be an employee and how to be someone who's successful in the economic space. If you're an African American living in most cities in this country in a segregated Black community, the local schools that your children are going to are usually not the best schools, right? There's schools that are under-resourced. There's schools that have a lot of students with a lot of social service needs, and the school is spending a disproportionate amount of its limited resources on social services rather than on education. If you're an African American and you're living in an urban area in this country, in most cities, then you're probably living in a house. If you own the house, you're living in a house that is probably not appreciating at the same rate as a similar house in a predominantly white neighborhood is appreciating. So therefore, the wealth creating benefits of home ownership that don't accrue to you because you're not in a home, you're not in a neighborhood where that house is going to appreciate. As a result, you're not able to take a loan out against your house, against the equity in your house, to send your child to college or to a private school, right? So I could go on and on and on with example after example after example of this. If you are an African American living in most cities in this country, you're living in a segregated area where that probably does not have access to full service restaurants or high quality supermarkets. In some cities, you may be in a neighborhood that doesn't even really have much of a legal economy. There are parts of New Orleans that basically have virtually no economy at all, right? Not even the illegal economy, it's just nothing there. So people are just doing whatever they do, or no one's living there at all. I think that is the underlying characteristic of American society that's the primary driver of the disparities that we see, not only in health, but also wealth, in educational outcomes, and also criminal justice in terms of incarceration. If you live in African American, live in a predominantly Black neighborhood in most cities in this country, then it's more likely that you're being subject to overly aggressive policing. So we go down the line, and I think it all stems from the fact that African Americans tend to be segregated into predominantly African American under-resourced communities around the country, just as Native Americans are disproportionately segregated into reservations in rural parts of this country. And as a result, their opportunities are also dramatically limited. And it's the same concept.
And so I would ditto that and jump in. And so I would just kind of, in summarizing what Thomas said, kind of put it this way: some of those social determinants that create these health disparities that we're talking about. One is poverty. I remember when I was in college, I won't say how many years ago, and one of my friends and I, we had to do a senior paper, and we chose to do it together. And there was a book out at the time about the poor pay more. we decided, even though the South was still segregated, to go into grocery stores in the neighborhoods around the university, which was a predominantly African American neighborhood, to cost out just basic goods that a family would buy: detergent, produce, etc. And we priced all those things. And then we went to the far north side of the city at a very ritzy grocery store and priced the same goods. We're just little college students at the time. And we were shocked at how much more the same brands, same products cost in the inner city neighborhoods than they did in the neighborhoods out in the suburbs. And so these differences have not gone away. When I look at what's going on in poor neighborhoods, whether they are Black communities, red communities with our American Indian friends, brown communities with our Latinx friends, we see these same kinds of disparities in poor communities. The one thing we haven't talked about, and I'm drawing now on my work in the substance misuse and addictions world, we know that advertising and marketing even of tobacco and alcohol are differentially conducted in terms of different populations. I was an expert witness many years ago in a federal court case, and this was one of the issues I talked about. If we go into a poor African American community, we are more likely to see billboards and advertisements for alcohol and tobacco that we would never see in an upscale white suburban community. We also know that many of those industries target and market to populations differently. Years ago, there was a commercial marketing a brand of alcohol. I don't know that I remember the brand, but when the one ad was done for whites, the tagline was something like, "Be a part of what's going on." Or the same ad, when advertised to the African American community, was done, that same brand, the tagline was something to the effect of, "Be different, separate from the rest." So even some of the things that are very subtle that people may not recognize or think about in terms of marketing, things that may contribute over the long haul to greater uses of alcohol or tobacco that we may see in poor neighborhoods. Some of this is also steeped in differential marketing, which is, I think, something for us to keep in mind. And so incarceration, environmental issues. Thomas mentioned he was from New York, and a lot of the tenements in New York cities in years past, lead was in the paint in a lot of the poor housing development. And we know about the impact of lead paint with all kinds of problems and mental health issues in children. And so again, it's a combination of so many of these, what I call social determinants: violence, environmental issues, poverty, that continue to create these health disparities in communities of color, and in particular, the African American community.
This is great information, and I think an hour and a half is obviously not enough time for this, and I want to make sure we touch on, people often hear me say this, and I know others do, you can't have health without mental or behavioral health. So I want to see if we can just address, as we're getting towards our last 15 minutes here, behavioral health in the African American community and some of the barriers that we see, and also what's preventing African Americans from getting mental and behavioral health services structurally, across the board, perceptions of providers, people that are doing referrals, all of the, I threw out a lot there, but I'm trying to get it because I know you guys have a lot to say on this topic, but I wanted to make sure we also brought in the behavioral health side of this because this is just as important. So Tom or Belinda, take it away.
I think this is more of a Linda question.
So I'll jump in. So first of all, when we speak to behavioral health, we're talking about mental health and addictions treatment. The piece I throw in and the conference that you mentioned, Patrick, I throw prevention in there because we often don't talk about prevention. And I think for me, prevention is core to the work that I also care about. So when we're talking about behavioral health, we're talking about mental health, we're talking about psychiatric issues, marriage and family counseling, addictions treatment. And usually we think about people like you, Patrick, social workers, psychologists, neurologists, psychiatrists, physicians. These are some of the people who provide that behavioral health to people who are out there. I think one of the things that I continue to notice is that we continue not to have very many people of color who represent those fields. If you look at some of the data, and I don't have them on the tip of my tongue, but we still see that the numbers of African Americans, Latinx, and American Indians who enter into these professions really doesn't represent our numbers typically in the population. So one issue when you talk about access, sometimes people need to see people who look like them to feel comfortable accessing those services. Now, I say that tongue in cheek because there are a lot, I want to give anyone the impression that everybody who's Black only needs to work with somebody who's Black. In matching people up to services, there has to be compatibility in a variety of areas. For some people, it might be race. For some people, it might be gender. For some people, it just might be someone who cares. So there's no one size fits all, but we still are not producing enough professionals in these fields. So I think that's one challenge that we're facing. I think that there is also this big stigma issue in a lot of communities of color. And because of the stigma of I am the problem rather than I have a problem, which is rooted in biochemistry and sometimes biochemical determinants, then people blame themselves and others blame them for challenges and issues related to their being addicted or having a mental health issue. And so removing the barriers and the stigma. And then the other issue is cost. Before coming to the university, I spent a significant portion of my career competing for money to start some of the first women's residential treatment programs in Oklahoma. I, in particular, wanted treatment centers where women could bring their children. A lot of women, for example, don't access treatment because they have nobody to leave their children with. So in the centers that I received funding for, not only did we include funding to support the children could live in the facility with their mom, and that was a really big carrot to get more women who needed treatment into treatment. So those are just some of the initial things I would throw out there. And Thomas, I'll toss the ball to you.
Well, I mean, I think you've covered a lot of ground there. I mean, I think, you know, the thing I would add to that is mental behavioral health services is difficult for everybody. I mean, we simply do not have sufficient access to behavioral health services in this country, period, regardless of race. It's a huge problem, but it's a bigger problem even for African Americans as well. And stigma would be another one of the issues that we put in. I'd say that many African Americans are hesitant to utilize behavioral health services because of stigma, and that is an aspect of this problem as well.
I think that's one thing that you brought up is great, is this idea of stigma. Obviously, mental health, huge stigma in this country for everyone, but then also being African American, added stigma. And what we talked about a little bit earlier, and you guys had touched on, was how do implicit biases play when you go to seek treatment or to be assessed or given medication for behavioral health conditions? How do you, Belinda, see that playing out in practice?
Can I jump into one last thing about stigma? Because this is, I mean, I don't want to, I wanted to add to the stigma thing, and then I think Belinda would be much better suited than me to answer that question you just asked. And it is that for African Americans, there's already a stigma of being African American, right? So there's this concept called hypervigilance. And I've written on this and some of the work that I've done, hypervigilance and how. And so if you're in a society that already you're already sort of considered, or you're already suspicious, you're suspect as it is. Many African Americans develop this practice we call hypervigilance. They are hypervigilant about making sure that they present themselves in a way that reduces the likelihood that they'll be subject to discourteous behavior by police, by store clerks, by anybody that they encounter. They worry about how they look. They don't want to go out to the grocery store unless they look a certain way, because they're concerned that they'll be mistreated or treated as if they can't afford to purchase anything in the store, that they'll be looked at as criminals. So if you're wearing a hoodie or something, you're worried about it. And so if you're constantly in this state of hypervigilance, and you're constantly worried about, how do I look? How am I presenting myself? How are people viewing me, right? And then you add to this, now you have this behavioral health need. And you may even recognize that you actually do have this behavioral health need. But now you're adding to this additional risk that you're going to be stigmatized, because now, in addition to all these other issues, now you got this mental health need. You have a substance abuse need, and you need treatment. It also has an impact, and this is how stigma plays out in an even more severe way for African Americans, because you have this baseline of suspicion that you're trying to guard against. And I'll stop, and sorry for interrupting, but I just wanted to add that.
Patrick, give me your lead in again. You were wanting to get to what issue here?
No, thank you, Tom. That actually said it beautifully. And that's a lot of times when people say, why are African Americans not going to addiction treatment or going to seek mental health care? People need to understand having a mental health issue is a stigma in and of itself, but then also everything in the stigmas faced by African Americans. Yes, exactly. It's this double. And I think that, thank you, Tom. We didn't plan that beforehand, but that actually is beautifully stated. It's important for providers out there that are listening. When someone comes and even presents, there's all types of things that are going on for that individual when they're seeking treatment or help. And I think that's important here. So thank you. I think this idea is, how do these biases play when African Americans come in for assessments or seeking treatment? How do those biases play out in practice?
Well, I think the practitioners often make assumptions. They look at you first before they know anything about you, and assume, because we have so many stereotypes out there about African American people. And so I think practitioners are more likely to assume that you may not understand what they're going to tell you. They make assumptions about your literacy level sometimes. I mean, it's all these things that have people feel uncomfortable. I think one of the things we haven't talked about too is money. Addictions treatment costs money. People on the wealthier end of the continuum will find the resources to get that care. When I applied for grants, it allowed me to give access to people who didn't have money. Sometimes people who are receiving Medicaid will be able to get those services. It's the people caught in the middle sometimes who are not wealthy and who are not poor on the lower end of the socioeconomic economic spectrum to have public assistance that are caught in the middle because they don't make enough money and they don't have access to resources to pay for those very expensive mental health and addiction services. So I think another big barrier out there is just cost, simply cost. The Affordable Care Act was attempting to address some of that, but that we still need to do more. It was a beginning, it was a good beginning, but there's still a lot more that needs to be done, I think, with the Affordable Health Care Act. I have my opinions about some things that we could do with that might, get it more up to speed. I think if we lowered the cost for young people, because it was kind of predicated on the assumption that we need a lot of healthy younger people paying into the system. I think if we lowered the cost for young people, we could get many more. And it's kind of that philosophy of, can we get more numbers? I think lower costs would get more numbers to help buffer those of us who are getting older, who are the ones who are going to need access and resources from the system. Perhaps that's been looked at, but most of the young people that I talk to tell me I can't afford to pay for the affordable health care premiums because they're costly, even for me. The penalties are less than paying for the insurance. So I think we've got more work to do on that. So I think those are some of them. I think we continue to have to deal with these implicit biases that people have. I know even as an educated African American with a PhD in psychology, I have always felt sometimes that if I walk into a room, people don't look at me the way they will a white man or a white woman and assume, oh, he or she is smart. And so I know that and this is probably true of some of my African American peers, are perceived sometimes as pushing what we know or saying things because we are trying too hard to overcome these stereotypes that people have that African Americans as a group are not smart, are not able to have the same mental muscle and capacity. And those things too, interestingly enough, Dr. Lavis talked about stress. It's all of those kinds of things in our institutions that contribute or that begin to also contribute to the stress that we feel because they're heavier burdens placed on us. In higher ed, we talk quite a bit about the burden that many early career faculty face because they feel the burden of having to mentor and coach and support students when they feel there may not be other faculty to support them. So they spend more time doing that than working towards tenure. And so we talk about those sorts of issues that also begin to create stress. And so if you begin to deconstruct all of the institutions in our country, I think we're able and we can begin to peel back those things that do, unfortunately, in my opinion, contribute disproportionately to the stress that many African Americans feel in terms of navigating spaces in this country along any socioeconomic rung. We know that poverty just exacerbates it, including access.
Wow, you actually had answered one of the next questions, and I was just looking at the time, and I want to, acknowledge and give you both sort of a wrap-up statement, what you think would be important takeaways from this event, If you can think of any action steps, what people can take. I wanted to, we can start with Tom, and then Belinda, you can kind of add your thoughts. And so why don't we just kind of go there and take it away, Tom.
Well, I know I, for one, enjoyed the conversation. Enjoyed listening to Belinda and learning from her. I hope that the audience also enjoyed it. I think it would be great if we put together a set of resources that I don't know if the organizers of this webinar, if you have access to the people that are on the webinar, or if they would want to have access to maybe some readings that they could do to further educate themselves on these topics. If there was interest, I know I would be happy to contribute a few articles or books that I think would be good for people to have. I think that, we have to continue this dialogue. We can't let this conversation end here. That we're never going to live up to the promise of the Declaration of Independence, one of the most beautifully written documents I've ever read. I don't know how many Americans have actually read that thing, but it's an incredibly beautifully written and brilliant piece of work. And if we're going to ever live up to the radical ideas in that document, that we would be a country that would be based on giving every citizen the opportunity to live their life in the pursuit of happiness, then if we're ever going to get there, then we're going to have to deal with this issue of race and start dealing with people as humans and not as different simply because of the color of their skin.
Wow, Dr. Lavis put a big cherry on top of everything you've said. I have so enjoyed being on this panel with you today, and I too have learned a lot from your deep experiences and background as a public health professional, and I feel like this is just the beginning of a great new collegial relationship, and I'm excited that we had this chance to share this space this evening. I think if I were bringing things to a close and to make some final comments, I would probably say this. Cultural competence for me is about doing with people, not for people. I think if we're going to deal with the health disparities that we've talked about this evening that continue to plague the African American community, that we really do need to have those who have the wealth, the power, the access, working with us in communities to truly understand those needs and to dig more deeply into understanding what strategies are going to be necessary, what programs are going to be necessary to deal with these issues. And I think we're only going to arrive at health equity when we move away from this very paternalistic model of reaching down in communities instead of holding hands and engaging with people and beginning to dismantle the systems that continue to perpetuate these inequities. That includes getting more people of color into medical school, that means better preparation, going upstream and ensuring that our children are being educated well and not miseducated. Dr. Lavis talked a lot about that. It means that we deal with these issues of crime in neighborhoods. And we know a lot. I think we know a lot about what needs to be done. The question is, do we have the will and are we willing to make the commitment with resources to do the things that need to be done? And I don't mean resources come and resources go. How do we sustain good things that we know that need to happen? And not only how do we sustain them, but how do we scale them across communities, across states, across the country to ensure the survivability of these changes? And on that note, I think I'll call it a night.
Well, thank you both for being here tonight. You've taught me tons. I've had 2 days having conversations, the three of us, and I've learned a lot. And all of the folks on the event, they've got a great foundation to build from. Keep learning. Thanks TPN. Thanks everybody for supporting Son of a Saint, who's doing great work in our community. And everybody in the audience, have a great evening. Stay safe and be well.
Thanks, Patrick. Are we going to have any questions?
Really didn't have really a lot of questions. I think there was such great words of wisdom. Really didn't see, we answered most of the ones that came up. They were, you guys were so great. It answered most of the questions.
Good.
Okay.
I will make a final comment. Thank you, Belinda and Thomas, of course, for being here, and Dr. Bordnick for helping moderate. I just wanted to encourage you so everybody here would hear me say, Belinda and Thomas, if you do have some resources, you are absolutely welcome to share with us. You can send it to anything that you have, to Trevor, to Abby, to Camille, to myself, whomever you have contact information for, and we'd be happy to compile them and send them to everybody who attended tonight. So thank you again.
Thank you.
Linda, I'd be remiss if I didn't tell you that not only is my wife a link, but every woman in my personal life is a link. Just
You're kidding me. I knew when you mentioned that, I didn't say anything yesterday. I thought, I bet his wife is a link.
yeah.
The
Yeah.
national organization is doing some phenomenal things.
Yeah.
I'll have to meet her when I'm there again.
Yeah, unfortunately, I mean, the National Assembly was going to be here
I know. I'm so disappointed.
next week or something. They
I
would
know.
get. They
I
would
was
get.
planning on being there.
Well, I don't think she misses not having to do not organize, not having to.
Well, the folks in my chapter are Zooming me to death. I mean, we're trying to do things by Zoom. It's been a challenge, but